Okay, so I'm very pleased to welcome Craig Cole, who you've been listening to during the day here, who has the task, the very interesting task actually, of talking about how do we approach the treatment of relapse myeloma, and to tell you a bit about what are some of these new drugs that are coming down the pike. So please welcome Dr. Cole.
Thank you. Thank you very much. Thanks for inviting me. Thanks for being here. It's great to have people come out to get empowered and to learn more about the disease, to pass on to other patients the message of hope and information, and that you can control this disease by being knowledgeable about it. And so I'm going to talk about relapsed myeloma. So how do you define what's relapsed myeloma? And we kind of use a few words interchangeably between recurrent, progressive, and relapse, but it's usually after a period of having a response to your drugs that the protein begins to go back up, and or you begin to have symptoms. And since myeloma doesn't have a cure yet, that most patients will at some point relapse. Hopefully it's far out into the future. And when patients, thank goodness these days that when patients have a relapse, they can actually achieve a second very good response, and now even a third good response. Refractory is a bit different of a condition. Refractory is when the myeloma has come back and then you try a new therapy and the drugs don't work in bringing down the protein. And that is an area of active research. So this is kind of the same thing in kind of a graph form. So the M protein, how much disease is right by where it says diagnosis of myeloma. So we start out with a high protein when you're diagnosed, and then you get your induction therapy, and the protein level and the amount of disease goes down by a lot. You then get a transplant, we prefer, but some people don't get a transplant, and they remain then they get maintenance, and they remain in a plateau phase. And you hope that that plateau phase is as long as possible. So a period of time goes by when you're on maintenance, and that is the first line of therapy. So what we call first line of therapy is induction, and you have a thought process of treatment up until the time of a relapse. And that is when the first line of therapy ends, when the protein begins to go up. And what we consider progressive disease is our standard is when the M protein increases by 0.5. So if your protein was 0 at the time of your plateau phase, and it goes up to 0.2, 0.3, when it's 0.5, and it's been over 0.5 in 2 consecutive measurements, then that is one definition of relapse disease. Also increasing in 2 separate measurements by the free light chain, or 25% from the lowest point. And that's a biochemical relapse. And sometimes people will call that just biochemical progression, where people can feel well at that point. And it doesn't necessarily mean that we have to treat at that moment, but you have to keep very close eye on the disease to see, is the protein going up and then leveling off, or is it going up? And we want to make sure we catch people with relapse disease before they are symptomatic. So the point is to really try and catch the disease before people have hypercalcemia, worsening anemia, or lytic bone disease. So the second treatment starts during the relapse, and hopefully not that high, and then you can achieve a second very good response. So, and usually if the disease has figured out a way to relapse off of a drug, that when at the time of relapse and response, usually we just don't put people on one drug maintenance. Usually if the disease has been able to figure out a way around the maintenance before, that when we choose the second plateau phase therapy, it's a maintenance, but usually includes more than just one drug to try and make sure that that stays down as long as possible. And that may be that the interval of the drugs are less. It may mean like when people get daratumumab once a month, that's kind of a maintenance therapy, but usually it's in a combination. And then that's the second line of therapy, which until the time, hopefully a long, long time from now, people will have a second and third relapse. And then hopefully that's a long time of when we do a second therapy, a third therapy. But usually the relapses will get closer and closer together over time. And at some point, when people will have the disease, when it comes back and you try a treatment and it doesn't work, the protein continues to go up despite the new treatment. And that's called refractory disease. And that's where the hammer of science and clinical trials really comes into play to beat that, oops, that was too fast. Well, I prefer that, to beat down that refractory disease. And as we do more clinical trials, we move that hammer closer to the time of diagnosis. So that's kind of the course of myeloma in 2018. Hopefully by the time it becomes refractory, something else has happened to them, because no one lives forever. So hopefully when people before they get to refractory disease, they'll get bitten by a shark, or I guess alligators kind of run around here, so bitten by an alligator, and that they succumb to other things besides their myeloma. So then, I counted that right now when we offer treatments for patients with relapse disease, that we have about 23 different 3-drug therapy options. So it used to be just 1 or 2 drugs, chemotherapy and more chemotherapy, but now you have 23 possible options, not including clinical trials, to treat relapse disease. So now we have to figure out, why should we pick a particular drug at the time of relapse? And the conditions that we look at is, well, how long did last therapy last? If you're on RVD and it lasted for 5 years, we may actually try that again because it worked so well. If RVD only lasted a few months, then we need to change therapies in toto. Do you have CRAB symptoms or not? Because if you're having symptoms from relapse myeloma, we gotta hurry up and have something that works very quickly, and not maybe a solution that is a bit more slow in activity. And the kinetics of the relapse. If the protein is doubling in less than 3 months, if it is doubling within weeks or months, then that's a pretty quick kinetic, and we need something that works more quickly than other options that work a bit more slowly. Also, do you have a high-risk relapse? And high-risk relapse means that the disease has changed its kinetics and now is behaving more aggressively and has more aggressive tendencies. So LDH is a chemical that's released when cells divide. If that number is going up to 600, that means the cells are dividing quickly and it's behaving differently than it did before. Having disease outside the bone marrow, so plasmacytomas in the tissues or in the skin, are high-risk relapses, and acquiring translocations that are known to be known in relapse myeloma, in particular the 17p mutation. And we'll talk about the secondary point mutations that can happen in myeloma that would be high risk. So you get disease-related, is it high risk or not, and then age-related, and the patient-related. So what's the level of activity? Was there a neuropathy now? Because if there's neuropathy now, I'm going to be reluctant to pick a drug like thalidomide to treat a relapse myeloma patient with, because that can cause worsening neuropathy. What are the blood counts, and is the kidneys impaired? Because the kidney impairment will narrow the choices of some of the drugs that we can use with relapse myeloma. And are there any blood clots or heart attacks and stroke events? Not so much because of the disease itself, but because those have a tendency to slow people down and they're not able to walk and get around as well as they would if they didn't have those conditions. So patient-related conditions, and then the regimen-related. And this is kind of a big thing of, what was your last therapy that you were on and how long did it last? Because what we don't want to do is we don't want to repeat a drug that had failed. So if you were on Revlimid maintenance, and the relapse happened on Revlimid maintenance, I'll be reluctant to use Revlimid again in order to try and treat the relapse myeloma. I would leave that drug out and pursue one of the other agents. And what was the previous exposure? And what's important is, if you had a transplant, how long did it last? Because if the transplant lasted over 3 years, and some people think over 2 years, that we can repeat the stem cell transplant and achieve again another very good response that can be long lasting. And so did you have a previous transplant? And if you did it last long enough for us to have that as an option? Does that make sense? I hope. So you get all that together, and then the most important part is that I tell people, so here are the options that we want to do based on your kinetics, your age, your performance status, and what your goals of care are. Do you want to try to get into eliminate this disease and bring the protein down to 0? Or do you not want to work that hard and just kind of have it smolder for a while? Do you want to come to the clinic every week, or do you not want to see me for a month at a time? And so there's a lot of things to consider, including clinical trials, when making a decision. That's a great thing because we have so many options now that we can actually tailor the therapy to patients' disease and what their goals of care are. So here are some options for myeloma at the time of relapse. And I broke it down on the basis of prior drug exposure. So a patient who is on Revlimid maintenance, if they relapse while they're on maintenance, and it's their first relapse, so knowing the line of therapy is important because a lot of the studies that are done in relapsed myeloma, the number of prior therapies is important because the more therapies, lines of therapy you've had, some of the drugs don't work as well in the 5th line of therapy as opposed to the 1st line of therapy. And so you see that if someone relapses off Revlimid, we're not going to repeat the Revlimid. We'll use something like Velcade Dex, and that's bold because that has randomized data to show that that therapy works well, especially in first relapse. If someone has a higher risk relapse, something like Pomalidomide Dex or Velcade Dex, and I put those are not bolded because they don't have as much randomized controlled trial data behind it, or like in the instance of Pomalidomide Dex, are still in clinical trials. If people relapse on Velcade maintenance, then again, the top 2 choices based on randomized controlled trial data and how well it works is Revdex and Revdex. Kyprolis Revdex, I should have bolded too, because that also has very good data. It's not necessarily randomized, but is very good data. And both at the bottom is followed by first or second stem cell transplant if you've gotten one or not. But there are options for lots of IV therapy, lots aggressive therapy if the relapse is aggressive or high risk, or something that's pretty easy like all pill therapy if the relapse isn't as aggressive and your goals of care aren't that aggressive. And of course, if you relapse off of maintenance therapy, then there's a whole host of different options, including Revlimid, Velcade Dex, and the antibodies. And should that mean that you should come off maintenance therapy in order to have your options opened wider at a time of relapse? No, because having the maintenance therapy keep the disease at bay longer is more important than having available options at some point, because this list will continue to grow and grow and grow over time. And so what if you have a second relapse or later? Again, you make sure that you don't repeat a drug that has failed unless it's remote, greater than 3 years ago. And then again, the playbook opens up a lot. Not all of these are randomized trials, but there's a lot of different choices. And the use of Pomalidomide is especially in multiple relapses of disease or in patients that have high-risk disease is preferable. And then, but you can see there's a lot of different choices here, including going back to thalidomide and panobinostat. You see, except for daratumumab, all these are 3-drug therapies. And just like Dr. Abenar had said, that when you look at studies for myeloma, that the 3-drug regimens the 3-drug regimens are superior to the 2-drug regimen. Just because of superiority doesn't mean that you have to fall into those categories. So you have to talk with your doctor about the risks and benefits of how you feel and the treatment, but the best treatment we feel is using 3-drug therapy. And then in late or aggressive relapse or at the time of refractoriness, you can use chemotherapy, but my allogeneic stem cell transplant, which is really a clinical trial agent, or you can go to clinical trials. And this is an insufficient list of the drugs that are currently in clinical trials for multiple myeloma. I could not put, if I just put lists of all the drugs in clinical trials, I would run out of time and slides and electricity. Because there are a lot of drugs that are currently being studied in myeloma. We'll talk about some of those in a little bit. So that's relapse disease, and that's kind of how we stratify patients on the type of relapse that they have, their goals of care, and their prior treatments, and is it high risk. And then we can pick from those options for you to match your goal of care. So let's talk about the antibodies a bit. Every plasma cell and the myeloma cells have certain proteins on it that identify it as myeloma. In the same way that my eyeball cells have proteins that describe it as an eyeball cell, just like I used to have hair cells and they have proteins on top of them that have failed me. The myeloma cell has proteins, and what we have done in the lab is actually created antibodies against those proteins. You don't make anti-myeloma antibodies naturally, or else you wouldn't have myeloma, so we had to build them in the laboratory. And the two drugs that are approved by the FDA right now are DARA and elotuzumab, but there are a number of antibodies, anti-myeloma antibodies in clinical trials. And of course, there's BCMA, which is the target for CAR T cells, and I'll talk about that in a little bit. So how does this work? Well, there's a myeloma cell down there, and then those are the myeloma surface targets that we talked about, like CD38 or SLAM7 that help identify it as plasma cells. And then when that manufactured antibody sticks to the myeloma cell, then it basically turns on your immune response. Anything that has an antibody attached to it is tagged for destruction. Usually it's bacteria, usually it's viruses, but in this case, we've made an antibody against myeloma, and who comes in are the good guy natural killer cells to destroy the plasma cell. That cowboy there used to have bullets flying down, and then people got upset about bullets. So I changed it to paintballs. They're lethal paintballs to the myeloma cell because the myeloma cell dies. Also, it will increase the number of T cells and macrophages which go in, and also hand-to-hand combat destroy the myeloma cell. Anything has an antibody on it has to die, and so the natural killer cells shoot at them. The T cells go to hand-to-hand combat, and there's an ancient part of our immune system called complement, which bores holes inside anything that has antibodies attached to it. So it's getting it from all ends, and the complement complements our natural immune system, and it kills the plasma cells. In addition to that, when these antibodies attach to their receptors, it causes a cross-link of the receptors, which then short-circuits the myeloma cell, which also causes it to die. So the antibodies do that all by themselves. And then finally, the myeloma cell is absolutely dependent early on in myeloma to the bone marrow stromal cells. That's where it gets all of its nutrients. When a myeloma cell has an antibody attached to it, then the bone marrow stromal cell kicks it out, because if you have an antibody attached to it, you must be a bad guy. And so the bone marrow stromals kick the plasma cell off, and then the plasma cell starves to death and dies. So there are a whole host, just like Dr. Abenar had mentioned, a whole host of mechanisms of action of the new antibody therapies. With DARA, again, it's CD38 is the target. It's actually a humanized IgG antibody. And as a single agent, it has a pretty good response rate of 30%. But when combined with other drugs, in the Pollux and Castor trial I'll talk about in a bit, fantastic responses. Elotuzumab is the other FDA-approved antibody, and its target is SLAM7, another surface protein on myeloma cells. SLAM7 and both CD38 and SLAM7 are expressed primarily on myeloma cells, and so it's a targeted therapy for myeloma. It won't work for other diseases like breast cancer or colon cancer. Elotuzumab, surprisingly enough, has zero activity as a single agent, but wow, it takes off like a rocket ship when you combine it with other myeloma drugs. And those studies are called Eloquent 1, 2, and 3, and Eloquent 3 is not finished yet, but we'll talk about some of those results. So talking about DARA, Pollux trial randomized patients between RevDex with DARA or RevDex without DARA, pretty simple. The one key is that they, on average, had just one prior line of therapy. So am I going to be anxious to grab DARA RevDex for someone on their 5th relapse? Not really, because I know that it works tested best in the first, after first line, or the first relapse. And the response rate's outstanding. DARA RevDex, 93% response rate. I never thought I would say that for relapsed myeloma. And just RevDex alone was 76%, but really it was the duration of that response that was really outstanding. That it still hasn't been reached about when people relapse on DARA RevDex on the Pollux trial. The CASTR trial is using Velcade. Again, Velcade Dex versus DARA Velcade Dex. And again, excellent response rate, superior to the 2 drugs, and excellent duration of response. And here, average of 2 prior therapies. So you can do it on 1, you can do it on 2, and that's where it's gonna work the best. Both of these trials are randomized, and the quality of life of patients with the addition of DARA did not hurt them at all. So people were out golfing on RevDex, they were out golfing with DARA RevDex. Probably the DARA RevDex people were better at golfing because they felt better. And then there's the Eliquis trial, which is that we were involved in using Darapomdex. And in that study, it's an average of 4 prior lines of therapy. And again, with patients that have had multiple lines of therapy, the response is very good, 60%, including some really good deep responses. And the side effects are here. The side effects are primarily infection and infusion reactions to daratumumab. And also, just like I think I mentioned on the next slide, one problem with DARA is the length of time that it takes to give. For daratumumab, the typical infusions, the first one is usually 7 to 8 hours, the second one would be 4 to 5 hours, and thereafter it keeps going about 3 to 5 hours for each infusion. That runs weekly for 8 weeks, and then every other week for 2 months, and then monthly. So that's a real pain in the butt to sit in a chair for 7 hours. And so there was something that was talked about at the, I shouldn't have said but, I'm sorry. There's a study that was done looking at the sub-Q infusion of DARA. And so here's the skin, and there's a skin up there, there's an infusion machine skin, and then this subcutaneous tissues. And the problem about just getting DARA and trying to inject any drug of that volume under the skin is there's not enough room under the skin with all the tissues. It'll just kind of balloon out, so it doesn't work very well. But what if you could use a drug, human hyaluronidase, to actually dissolve a little bit of that fat tissue under the skin and allow more of the drug to be infused under the skin. And it doesn't hurt to have this drug placed under the skin. You really can't tell that there's anything there other than a little bump where they first infuse the drug. And the infusion is just 15 minutes. I'm sorry, 3 to 5 minutes. And then you can actually have the drug absorbed by the blood vessels under your skin over a period of time. And it actually, and in the initial trials, it appears to work just as well as regular daratumumab given IV, and the infusion reactions were significantly less because the absorption of the drug was much, much slower. So we're gonna be watching for more trials of using subcutaneous DARA, but it's really gonna revolutionize things to be able to get a sub-Q injection instead of a long infusion. For elotuzumab, the ELOQUENT-2 trial, same thing, Elo RevDex versus RevDex alone, excellent response rates. This was a little bit more prior therapies than the DARA Revdex, the average of 2 prior lines of therapy. But again, excellent responses in this group and excellent duration response. The infusion reactions are a little bit less with elotuzumab, and the infusions are a little bit shorter with elotuzumab. There's elotuzumab Velcade Dex versus Velcade Dex alone. And again, even though they're pretty comparable response rates, it was the duration of response that was longer for Elo Velcade Dex than Velcade Dex alone. And again, without much in the way of infusion reactions. Elo Pomdex is a trial that we are still involved in. It's very early data on this, but 77% of patients remain on therapy, so they have responded. We're still waiting to calculate the depth of the response that they have, but they have also had 1 to 3 prior lines of therapy. And Elo PVD, Elo Pom Velcade Dex, again, we are just submitting the abstract on that, and response rate with over 4 prior lines of therapy, again, very good response is 62%, and especially those patients that have already failed DARA, which is becoming one of the things that we're concerned about, is what you do after DARA. Very good response rates in patients that have failed daratumumab. So those are the antibodies and relapse therapy, and I'm gonna move into some of the new stuff. So we're gonna talk, anybody wanna talk about CAR T? Talk about CAR T? So here's a Model T. That's funny in Detroit. Everyone laughed in Detroit. Oh boy, this is the funniest slide I have. I laugh at this in my office. I just giggle every time I see, get it, CAR T, Mr. T in a car, CAR T. You know, that's funny. I just love that. Oh my gosh, I should get a tattoo that has it on it just because I just laugh every day looking at my skin. This is a real CAR T. So CAR T 101. So T cells are a type of white blood cell that attacks viruses and hunts down cancer cells. CARs, chimeric antigen receptors, are receptors that help those T cells hunt down cancer. So the CAR helps the T cells hunt down cancer. So what if we could program the patient's T cells with chimeric antigen receptors to have those T cells hunt down cancer cells? So how do we do that? So what we do is we get the patient with relapsed myeloma and we harvest their T cells with apheresis, much in the way that we harvest stem cells when we're gonna do a transplant. But instead of stem cells, we're harvesting T cells. So we get the T cells from the patient, and then we put it in a petri dish with a virus that contains the gene for cancer-killing CAR. So the gene to have the cell create the receptor to kill cancer is in this virus. The virus infects the T cells, and when viruses infect T cells, it'll inject its own DNA into the DNA of the T cell, and that virus will then hijack the T cell into doing what it wants. In this case, we've hijacked the T cell to produce cancer-hunting chimeric antigen receptors, or CAR. So this T cell that is kind of swimming around in the blood minding its own business has now been reprogrammed and repurposed to hunt down multiple myeloma. Then we grow those T cells in mass quantities, in millions and millions and millions, and then re-inject that into the patient, where it goes and immediately hunts down the cancer that's causing the problem. And if you want the non-technical version, here's the non-technical version. T cell, virus gets in T cell becomes cancer killing. Make sense? So in myeloma, so BCMA is one of those receptors on myeloma cells that we've talked about that we can use as a great target. And here's BCMA on a plasma cell. And again, we genetically modify the patient's own T cells to express cancer anti-BCMA, or this virus will hunt down anything that has BCMA on it, including myeloma cells. So it goes to hunt down the myeloma cells, kills the myeloma cells, and we hope the T cells are reproduced inside the body, making more T cells to go hunt down myeloma cells. So there should be an ever-ending therapy, part of your immune system that constantly hunt down multiple myeloma and be able to keep it in a good response. And usually that's after 9 days before we reinfuse it. There have been studies that were been presented at all our conferences because this is such exciting data, and I will talk about two of them. One is a University of Pennsylvania study using anti-BCMA CAR-T, and this, as you know, University of Pennsylvania had developed the leukemia and lymphoma CAR-T therapies, and they were also working on a myeloma CAR-T. They broke it up into three groups. The first group got high-dose CAR-T. The second group got chemotherapy to wipe out the immune system to give the CAR-Ts an unobstructed view of the cancer. So CAR-T, then chemotherapy, then low-dose BCMA, and then the third is chemotherapy plus high-dose CAR-T. And then they expanded those trials. And these are people that were pretty sick with myeloma. They had had up to 7 prior therapies. Most of them had failed carfilzomib, pomalidomide, daratumumab, elotuzumab. They were younger patients because of the fear of some of the side effects, and almost all of them had high-risk myeloma at the time of their relapse. And so here's the results of the study. And in the green are really good responses. So the green happy face, these are patients, these are individual patients, 1 through 17. And green means that there was a good response. And one person had a really good, long-lasting response with CAR-T. There are a lot of very good responses, some stable diseases, and in the third cohort, some partial responses, and 1 complete response. So for such a high-risk group, this is a pretty good result, about a 64% response rate, and with the high-dose CAR-T, 53% response rate, and the duration of response is only 4 months. So it was a bit short-lived, but again, for a high-risk group, there are good responses. So now we're going to switch to another CAR-T, the Bluebird CAR-T, which is another CAR-T product. This was another group that had multiple prior lines of therapy. They tested them to see if they had the protein in the very first parts of the study to see if they had BCMA on their plasma cells. And after it got going, they didn't look anymore. And again, they had the T cells collected. They gave them chemotherapy, so the CAR-T has an unobstructed view of the cancer. And then they gave them between low dose and high dose CAR-T infusions. And this has quite a bit different response rates, even though this is very early, and it is a very small number, 21 patients, very small number of patients. The overall response rate was 100%, including 74% that had really, really good responses, complete responses, and very good partial responses. And again, after a few months, after about 6 months, the responses actually deepened. And it worked very quickly. The responses were in the first month, and the median progression-free survival hasn't been reached yet. But then there are side effects, and the biggest side effect that people experience is cytokine release syndrome. So when your immune system turns on at a drop of a hat like that, it can really cause a lot of chaos in the body, including very high fevers, low blood pressure, high heart rate. The high fevers can cause muscle breakdown, kidney damage, liver damage, shortness of breath. Some people have to go to the intensive care unit. And but they're short-lived. They happen in the hospital. You don't go home feeling that way, of course. But and then any cytokine release syndrome, 83%. For the UPenn, 71 for Bluebird, severe 33% and 10%. So again, that's why they had younger patients getting these therapies. There were deaths on both trials due to progressive disease and infections. And so it has risk now, but we're getting to learn how to treat cytokine release syndrome much better than when we first started. So again, these are not all CAR-Ts are the same. There are lots of different CAR-Ts, and there are a lot of different companies that are in the CAR-T business these days. And the thing about, I know if I give daratumumab, it's kind of the same drug in every study that's done. I mean, it's the same drug over and over again. CAR Ts are very different from each other. One CAR T can work very well for some patients, and another CAR T can have really outstanding responses. And so we still need to see the maturation of a lot of these studies in order to know how well does this work. I'm really excited about something called a BiTE antibody technology, which basically is a hybrid. You get an antibody that gets T cells, you get an antibody against myeloma, and you get the best parts of the antibody, glue them together, which then, instead of injecting a virus inside your own T cells, why don't we get your own T cells and force them to attack the myeloma instead of putting a gene in them? And the idea is that it does kind of the same thing. We're hoping that and those studies are just starting. So I'm just gonna talk about one more thing. So that is how to harvest the immune system to treat myeloma in trials. So what about attacking the mutations in myeloma? And we did a study at U of M looking at almost 200 relapsed myeloma patients who had a bone marrow biopsy. And we analyzed the DNA of the plasma cells. And we analyzed the DNA of the plasma cells looking specifically for 2,000 different mutations that we know are important in relapsed myeloma. And we found 76% of those mutations had drugs approved to treat those mutations for other cancers, breast cancer, lung cancer, and bladder cancer, and melanoma. And this is what we found as for the mutations with relapsed myeloma. And these are different mutations, NRAS, KRAS, BRAF. They all have these funny, there's 1114 mutations. They all have funny names, but that is what relapsed myeloma looks like. It has these point mutations that can't get picked up on usual FISH testing, although chromosome 17 was also an acquired mutation or deletion in some myeloma patients. The great thing is that there are drugs that target all those. And so there are targets for MEK, for KRAS mutations, NRAS mutations, for FGFR3 mutations. And I'm gonna concentrate on a drug called venetoclax, which targets the 1114 translocation for BCL2. So when plasma cells grow, they use cytokines, and they will signal a little through BCL2 to make pro-survival proteins, which keep the myeloma cell alive, right? If you have 1114 translocation, if your 11th and 14th chromosome are stuck together and are transcribing information between these two chromosomes that never should meet, you make a whole bunch of BCL2, which makes a whole bunch of proteins that keep the myeloma cell alive and not die. They don't proliferate very quickly, but they don't die either. And so it's a buildup of all these cells that have the 1114 translocation. What if we got rid of BCL2? What if we got rid of the gene or the transcription factor which makes the myeloma cell produce all these anti-death proteins? If you get rid of BCL2, we hope that the myeloma cells will start to die instead of staying alive, and without very many side effects, which makes patients really happy. And there was a study that looked at this. So they gave venetoclax, which is a pill, to patients with a relapsed myeloma, and it was pretty crummy results in just giving venetoclax to everybody. That didn't work so well, a 21% response rate. But if you gave it to patients with just the 1114 translocation, you saw the response rate double to 40%. And if you did further testing to see if those 1114 translocations were making lots and lots of BCL2, when you treated those patients with this pill without dexamethasone, just targeting the mutation that's driving the cancer, there was an 88% response rate, and some really good responses. And with low BCL2, again, not as much. And so targeting the BCL2 actually works, is tolerable. There was some nausea and vomiting, but there was no tumor lysis and no serious toxicities. And again, there was no dexamethasone. And it didn't matter how many prior treatments you had had. So all the other studies, it works better in first relapses than in last relapses. The venetoclax, if you had the 1114 and increased BCL2, it didn't matter. So that's precision medicine. Instead of just picking something off the shelf where patients will benefit, some will no benefit, and adverse events, the precision medicine looks just at, we do a DNA test looking specifically at the target driver of your cancer, and we apply the drug for that, for your particular mutation. It won't work for other people, but it'll work for you, and then you end up being happy and smiling. Clinical trials. This is amazing how this has happened. I was there when we started. I am older than I look, I hope. Probably not. My wife is going to kill me. We did clinical trials, and they were crummy. They had lots of side effects, and they didn't work very well. But slowly, as we did more clinical trials, the clinical trials got better, they were smarter, they had less side effects, and they were more effective. We used to have relapse treatments that would only work 30% of the time. Now we have relapse treatments that are standard of care that work 96% of the time in first relapses. And so it is inevitable that the progress that we're making at the velocity that we're making it with will result in a cure. And I used to not have this slide until recently when I saw things were so hot for this disease that we had 13 times the number of approvals than other cancers, that we are heading up to a cure, no doubt. And the thing is that the applause is for you who are involved in clinical trials who helps do that. I just relay the information. I'm just a paper boy. I just here's the news. But you guys make the news by being involved in clinical trials.
Well, you're one hell of a paper boy.
Thank you. So relapsed myeloma, when the cancer returns, is all hope lost? No. We have more available therapies than we've ever had to treat myeloma, and we can target it and make it to meet your goals of care. Since myeloma doesn't have a cure, people will likely relapse, but is now more important than ever to be informed, because your doctor may not know all there is to know about myeloma. No one knows everything to know about myeloma, but you should say, I've heard about this clinical trial, I heard about this new therapy. What do you think about this? Engage your physicians and be empowered to get access to these new therapies for you. And great changes are coming quickly. And I would say that definitely one of the best sites to go to find clinical trials is the Myeloma Matrix. And this is, as you know, the website. If you pull down Advancing Treatment, Myeloma Matrix is right there. It gives you clinical trials based on your stage and where you live. The government also has a clinical trials site. You have to know your diagnosis to get in there. But if you go to cancer.gov, there'll be a big purple box that will follow you all over the website that will say clinical trials, click here. It is incredibly annoying, but it will get you to click to find clinical trials where you live. Thank you.